Hi, Stephanie. Thank you for presenting today. We'll give everyone till around 1:05, and then we can get going.
All right, well, thank you for having me and for having us, me and Jason.
So how many psych patients does everyone have?
Too many.
We hit a record 42 last week, Lay, here in at Connecticut Children's.
I thought they all came to me.
That's what I was hoping for. I was hoping that it would go down south, but they didn't.
Connecticut's in bad shape, guys and gals, but
I don't know about besides psych patients for having our volumes have just skyrocketed. It's everybody decided that it's just time to come back.
Yep, same here. So in top of the psych, it was we had a couple of days last week where it was really, really. It felt like we didn't see as many patients before, but it felt like we were seeing more just because there was so much going on. But it's 1:05, so good afternoon, everyone. Thank you for coming again to the session. Today we have two presentations. First one will be by Stephanie Cohen, and then we followed by Marla Levine after this one. So thank you, Stephanie, for presenting, and you can take it away and share your screen.
All right. Hold on. All right, can you see that?
Yes.
All right. Well, thank you for having us, inviting us to present today. I hope we have some cool cases that you'll enjoy. And I'm going to be having my fellow Jason is going to be presenting a few cases. All right. So the first case was a 14-year-old girl who initially presented to an outside hospital with complaints of abdominal pain for 3 days. She had complained of some intermittent belly pain and really not localized, so it made it a little bit difficult. She had associated nausea and anorexia, some urinary complaints, and she reported a tactile fever. The labs from the outside hospital, really not impressive, but just wanted to list them here. Her white count was normal. CRP was also in the normal range, and chemistry not, didn't show anything significant. But her urine was concerning. That showed 3+ esterase, elevated white cells, as well as bacteria. But according to the note from the outside hospital, they elected to transfer her for evaluation of appendicitis or ovarian torsion because they were concerned about her belly pain. So when she came over to us, she was afebrile, and otherwise she didn't appear in any distress. And her exam was just notable for right lower quadrant tenderness without rebound or guarding. And so in light of the fact that they were concerned about right lower quadrant tenderness, we went ahead and evaluated that area. And this is what we saw. So this is a transverse view of the right lower quadrant using a linear transducer. And you can see in the far field, you can see the vascular structure that is at the level of the external iliac artery. The vein is deep to that. And then there was this just not defined mass. So adjusted the depth and to get a better look, but still not able to see the entire mass. So switched over to a curvilinear transducer. Sorry. And this is what we saw. This is, again, still in the transverse view. What do y'all think about that? Can't see. Anybody know what that is?
I have no idea what, I mean, obviously, we're concerned about the mass. Were you able to feel that on the exam, the mass, or
no? No. So, I mean, you can see here that, again, we're in that right lower quadrant area. You can see here's the psoas muscle. Can you see my pointer?
Yes.
Here's the psoas muscle, again, the external iliac artery and vein. And again, with this mass, I didn't put color flow on it at the time.
Does it look like a horseshoe?
It doesn't look like a horseshoe, but it certainly looks kidney bean shaped, definitely. So we went ahead and interrogated the right upper and the left upper quadrants, and you can see in the clip on the bottom left, that's the left upper quadrant. You can see that there is the kidney there, but in the still image on the right upper quadrant, I'm not sure why I didn't have a clip there too. You can see that there's an absent renal fossa. So this is an ectopic kidney, and ectopic kidneys develop because of an abnormality during fetal organogenesis. They don't ascend to the correct location, and they can occur at several different places outside of that renal fossa. Usually, they'll be asymptomatic unless they become obstructed, in which case they can lead to stones or to infection. You can also get what's called cross-fused renal ectopia, where the kidney can cross over to the other side, and you can see if it fuses, you can cause the horseshoe kidney that you mentioned, right? And or it can cross on the same side. So once we decided that she had nothing surgical, we hydrated her, gave her pain medicine, antibiotics, and she was discharged home with antibiotics and had no problem with her course. So I thought that was a neat case where, you know, ultrasound really was helpful in evaluating her abdominal pain, and was able to determine what was the underlying cause. Our next case was a 13-month-old who presented. Of course, it was about 2 or 3 o'clock on a Saturday night, Sunday morning, and he was coming in with vomiting and fever. He started vomiting 4 days earlier, and saw his pediatrician, who had prescribed him Zofran, but he continued to vomit despite the Zofran. He was tolerating fluids, but was still not able to tolerate any solids. And the parents reported that he hadn't had a bowel movement in 4 days. The day prior to admission, he developed a fever, and the parents decided to bring him to the hospital when they noted that he was breathing quickly. So I oftentimes when I do presentations, I try to put in the pertinent physical examination and highlight what is relevant in this case, which in this case, it looks like everything is lighting up. Like when we were in medical school and you highlighted everything, it's better to just cross out what was normal. So he was febrile, he was tachycardic, he was tachypnic, he was in obvious distress. And this is not a picture of our patient, but he had abdominal distension, absent bowel sounds, and was very tender. And he had poor perfusion as well. So, when we see these 13-month-olds come in with a prolonged course, I think most of us, what would be your top differential for this child? I think most of us would be concerned for like a perforated appendicitis. So with that, we went ahead and we went looking in his abdomen. So this is the transverse view in the middle of the abdomen. And what are we seeing here in the middle? Any idea?
Is that like a dilated loop of bowel right in the middle?
Yeah, that's a pretty dilated loop of, oops, sorry, I didn't mean to go forward, but here's the next image. You can see, here's that dilated loop of bowel, and you can see that beneath that, there's another dilated loop of bowel in cross section. And we're not really seeing a lot of peristalsis and a lot of movement. So, what are you concerned about when you see this?
Small bowel obstruction.
Small bowel obstruction. So when we think about the signs of small bowel obstruction, of the to and fro peristalsis and the plica circularis, and sometimes you can see the tanga sign or free fluid, this image is, we're kind of progressed past that. This is actually pretty ominous when you get to that aperistaltic sign. And I put this in, I actually inadvertently cut off the measurements just to show the size. And this was a question I wanted to ask the group. So I was just showing that it was at least 2.5 centimeters is what is used in the adult literature for dilated bowel loops. In the pediatric radiology literature, what I found is for children greater than 12 months, they use 2.5 centimeters. For children who are younger, the radiologists use the width of the child's vertebral body, which you can see on X-ray, which of course, I guess you could measure that also on ultrasound. So what criterion are y'all using to diagnose dilated bowel loops or possible SBO in your small children.
I go on especially what you just went through, except the size, because as you remarked, there's not really anything that would gives us anything in terms of the size. So it's good to know that there's some literature on the reality of that. But I sort of use the lack of movement and then the plia preclaris and the tanga sign if I see it. But you know, haven't seen a lot of those. But you know, the measurement I take it just for you know academic purposes. But I don't know if anyone else uses the size that you mentioned, like 2.5.
Yeah, that's probably what we're looking at from a Gestalt measurement standpoint. I think the challenge that I've encountered with patients that have signs and symptoms of SBO by ultrasound is you have to correlate clinically. I've definitely seen some enteritis, you know, even like active enteritis with ileus or post-viral ileus patients with similar, you know, dilated fluid-filled small bowel with some to and fro. And I think I had one kid not too long ago that actually had complete aperistalsis, and you know went to the admission and X-rays, and I don't think ended up getting a CAT scan, but ended up, you know, making sure that it wasn't a surgical cause of obstruction. So it's just I find it challenging because not all, in quotations, what we think is SBO by ultrasound ends up being a surgical emergency. So it's tough.
Yeah. What I have found, and that's interesting, Antonio, is most of the time when we see patients that we're concerned about an SBO, the surgeons, they don't seem to believe it. And we've had several kids who have sat on the floor for 5 or even 6 days and until they get surgery. I haven't seen any I haven't had any scans myself that I you know, that had aperistalsis or to and fro that ultimately wind up being post-viral gastroenteritis, but I'll keep my eye out for that. So this child, of course, we were concerned, especially given his, you know, his shocky state, and we did consult surgery, and they requested that we get plain films. So at 13 months, we usually get a flat plate and a decubitus for our 2U. And those showed multiple dilated loops of bowel, mostly in the proximal intestines with dilated dilatation proximally. There were multiple air fluid levels, but no signs of perforation. And so, of course, surgery still wanted to get further imaging, and they requested an upper GI series, which you can see that there's the normal C-shaped loop of the duodenum, and that indicates that there's normal rotation. So this is not from malrotation, but you can see that the contrast does not progress distally. So this is definitely a proximal small bowel obstruction. So he was taken to the OR, where they found that he had a congenital band that extended from the cecum to the ileum. And this caused closed loop obstruction, which developed in about 40 centimeters of ischemic bowel. They were able to lyse the bowels. They had to remove the dead bowel, and then created an end-to-end anastomosis. So he did well and didn't have any complications. Yeah, no bueno. So I just was, you know, looking at, you know, we talked a little bit about size, which again, there's not much in the pediatric focus literature about size, but there's a lot in terms of sensitivity. And so this was a recent study in Annals just a few months ago out of GW. And this was a single center study, and this was focused along all levels of training. So it included experts and novices as well. And so, you know, we think of CT as being the gold standard, but they actually had a pretty good sensitivities, 87.5%, which most of the literature quoted can go up to the 90s% in specificity of 75. So across all different levels of training, I thought that was pretty good. What's more impressive actually is the time. And I don't know how long. I imagine that in adult emergency departments, this takes a lot longer. But you're seeing an almost 3-hour difference diagnosis of ultrasound versus CT. And I think, again, I'm preaching to the choir, but I think that really shows, how powerful this is and why we obviously need to continue doing that. Sorry. Anybody had any comments or wanted to share about your experiences?
We had a surgical conference recently where they had stated that they expect like dead bowel essentially within 6 hours, which I didn't, I guess I didn't quite realize how short a time we were talking, and really kind of, further impressed upon me how any time-saving measures in some of these circumstances can make a huge difference.
Yeah, I know. We often think about the teenage males who come in with like testicular pain. We think time is testicle, but I guess that really pertains to intestines as well. All right. So we'll take a little change from the abdomen, and this was a 16-year-old girl who presented with a right ankle injury during a tennis match. She said that she felt a pop with sudden onset of pain. She was not able to bear weight and she needed help to get off the tennis court. On exam, according to the note, this actually wasn't a patient that I saw. She was noted to have diffuse swelling over the Achilles and had tenderness over the calf, and she wasn't able to move it. According to the note, they did state that after she was treated with ibuprofen, her pain was much relieved. But they did go ahead and get x-rays, which I did not include, and those were reportedly normal. But because of her decreased range of motion, the resident who saw her did go ahead and take a look with ultrasound. And this is what they saw. So this is in the top, that you can see a transverse view of the posterior leg, and in the lower image, you can see a longitudinal image. What do you see here? Anybody want to describe what they're seeing? Sorry, I'm looking at the chat. Yes. Who wants not meet? Who wants that? So in the upper image, you can see, sorry?
The chat says ruptured Achilles from Carolina, and two ends not meeting from Lee Chen.
You can see that there's an area of, as it spans through, there's an area of edema and fluid in the short axis, and you can see the same on the long axis. You can't see the fibrillar tendon. Here, just a little more close up, and the reason why I put this image in here, you can see they're doing a really nice job of fanning through, trying to demonstrate anisotropy. You can see that there's some, fibrils over here distally and some proximally, and just you see edema, and they're just not meeting in the middle. And here's just again, you can see that edema and fluid collection. And here's the nice normal side. You can see again that nice fibrillar tendon, and again they're demonstrating that there is anisotropy of this uninjured and ruptured tendon. So she was put in a posterior splint inflection. She followed up with orthopedic surgery and had an MRI several weeks later, which again redemonstrated that complete rupture of the Achilles with 3-centimeter distraction. So, one of the things I was really happy about when I saw, when we reviewed these images in QA, this patient was seen by one of our emergency medicine residents who are more apt to pick up the ultrasound probe than our pediatric residents. And we know that MRI is the gold standard, which of course we can't do on every patient who comes to the emergency department. And the literature shows that the physical exam, especially in cases of partial tears, can miss cases of tendon rupture because it's too swollen or because the patient's in too much pain. And so POCUS is really a nice adjunct, for evaluating these patients. How often are y'all doing this in your shop?
Actually had a case, I think it was a couple of months ago,
Mhm.
and then we didn't have MRI, so actually pretty expedited care because ortho actually wanted to look at our images, and then the main difference they wanted to tell was a complete rupture versus just partial rupture.
Mhm.
So we were able to say that it was completely ruptured, so they ended up going to the OR. So it expedited care in my case, but I haven't seen rupture Achilles in a while either. So.
So did they take her to the OR immediately, or was that like scheduled follow-up?
She was complaining also of pain because it ended up being traumatic.
Mhm.
Like it was this freak accident that if she was in the garage and some piece of metal from the gate flew and kind of like just like kind of poked her. So that's the way she described it, like a bee sting, and then she couldn't move her foot. So she ended up staying just I think overnight, and they took her to the OR the next day.
Oh. Yeah, this was she saw surgery a few weeks. She saw orthopedics a few weeks later, and I don't remember when exactly she got her surgery, but it was not within that visit or within that week. All right. So I'm going to turn this next one over to Jason.
Hey everyone, I'm Jason Gillen. I'm the PEDS ultrasound fellow at Emory this year. Thanks for having me. I got a couple cases of right lower quadrant pain to present that don't turn out to be Appy's surprise. And the first one that I like to present is this 11-year-old girl with vomiting. So she's coming in with a one-day history of vomiting and right lower quadrant pain. I saw her in the morning, and the story was that it kind of started last night, pretty much in the right lower quadrant. She was having that pain all through the night, vomited several times. She did have some abdominal pain and vomiting a few weeks prior. That ended up resolving, had obtained a Zofran prescription from that presentation. I was taking some Zofran over this past night, but continued to vomit through it. And her exam is really just notable for some peritonitic right lower quadrant tenderness. And so here are the images. Obviously for this girl, I was thinking torsion versus Appy. And so I like to start with a curvilinear probe and just get a view, a transabdominal pelvic view. And this is what I ended up seeing. Any thoughts about what we're looking at? And feel free to type in the chat box since I have that open. So a large cyst, ovarian cyst, and people agreeing with ovarian cyst. Definitely something I thought about. You can kind of catch the ovary coming in this sagittal view right here as I'm fanning through. Yeah, right there. What kind of struck me was how kind of tubular this structure was. And so, but definitely think something pelvic, ovarian, and I sent her for a formal pelvic ultrasound so that my radiology colleagues could help me out and help determine whether this was torsion or something else. Next slide. And so the radiology performed ultrasound actually demonstrated normal ovaries bilaterally, good blood flow. Not concerning for torsion based off the size. Did not think that structure was attached to the ovary. They did not see an Appy, but they said in their read that given the location of that tubular cystic structure next to in the region of the ovary, that they were more concerned for hydrosalpinx. And so Meckel's is a good thought. See that in the chat box. This was not a Meckel's. And yeah, as Matthew said, fluid field structure, not 100% convinced it's ovarian in origin. That was my impression as well. So I consulted surgery. They were a little baffled and requested a CT scan.
I just wanted to ask, I see in the chat box,
Mhm.
Antonio has a double bladder barrel sign. I don't know if I don't think I've heard that before. What is
I pretty much just made it up, but
that? Oh, okay.
as Julie Leviter says, two bladder-like appearing structures in the pelvis is never a normal finding. So
You,
kind of
I like that, and I definitely agree.
falling
you should
short.
copyright it.
And so here's the CT scan and the best axial image for you guys. A big tubular cystic structure in the right lower quadrant is compatible with hydrosalpinx that with kind of our clinical presentation was concerning for tubal torsion. And so at this point, surgery ended up taking her to the operating room. Next slide. And so she had an emergent laparoscopy and she had an isolated right tubal torsion. The entire tube was necrotic and they took that out, but the ovary looked fine, well perfused. And so a little bit of a interesting case. Next slide. I can't remember if we have another one. So backslide. And so for isolated tubal torsion, very rare. It's about 1 in 1.5 million people. And you can get ovarian torsion. You can also get tubo-ovarian torsion, but it's usually the very kind of proximal part of the fallopian tube where the ovary is. And when you have an isolated tubal torsion, it's usually kind of the midpoint of the fallopian tube that's twisting. What I think may have happened, what I've seen kind of looking at some case reports, is that during the laparoscopy, the patient had a left paratubal cyst that was noted and taken off. It's been described that paratubal cyst can kind of be lead points for torsion. And so they didn't describe one in the operating report, but the whole mass was so necrotic that I'm suspecting there may have been a lead point of a paratubal cyst on that side as well, but unclear. But definitely an interesting case of, you know, right lower quadrant pain, peritonitic, not always going to be epi, not always going to be torsion. Because it was something I'd never seen before. I don't think this really helped expedite care, and surgery was a little at a loss too. So still went down probably a similar clinical pathway that most people would have been down, but now something more on my differential than what was previously. Any questions with this case?
Does it matter that the ovary wasn't involved? Only in the sense that, I mean, if you're taking out the fallopian tube, that ovary is no longer functioning for you, right? I mean,
the ovary is no longer, I guess you could harvest eggs from that ovary if there was ever a fertility issue with the ovary being viable, but it's not going to be able to ovulate into that tube and be able to conceive that way. And so I was thinking about that too, but
did they leave the ovary inert?
They did.
The ovary?
Yes.
Interesting.
Yes. Yeah, the ovary looked great. The tube was just a huge necrotic mess, and they took the entire tube out, but the ovary itself looked great. Was well perfused, wasn't ischemic, no sign that it had been torsed.
Interestingly to that comment, Zach, I have a good friend who had to go through surgery for an ectopic in her tube, and she'd also had a cyst on the contralateral ovary for a long time. So they ended up taking the ovary on one side and the tube on the other. And her insurance company refused for a long time to proceed with IVF because they said it's theoretically possible to them that she could shoot an egg from an ovary from one side across to the other. So medically not viable. Not everybody buys that.
Weird.
All right. Any other questions with this case? All right, we can go on to my next one, which was another right lower quadrant pain that I just saw on my shift last Thursday. So I was upset to miss Dr. Dina Hand's presentation, but I heard about it from Dr. Cohen. And this was a 12-year-old male with right lower quadrant pain. Pain started for him about 5 days ago, but really increased in the past 24 hours. Really no other infectious symptoms, no vomiting, diarrhea, or fever. His pediatrician had seen him and was so there was like a psoas sign, and so referred him in here for basically a rule out appendicitis. Had a history of very complex congenital heart disease, was DTGA that was repaired, but then had a host of additional corrective surgeries. And interestingly, had this baseline asymptomatic bradycardia in the 30s. So I had to reset the alarm monitors so it wasn't beeping the whole time. But otherwise, like, doing well. This kid was actually playing baseball at the point that he noted this pain. And so for this past 5 days, he's like, maybe it was a muscle strain. That's what his mom was thinking. But for it getting worse in the past 24 hours, and then with the pediatrician thinking there was some peritonitic signs, ended up seeing me in the ED. And on my exam, he wasn't really tender at McBurney's point. He said maybe a little bit, normal GU exam. But if you asked where he was tender, he would kind of point more in this like right flank area at the level of the belly button, the umbilicus, and more kind of like a lateral anterior area, not kind of flank like CVA or anything like that. Next slide, please. And so this was just, I always like to rule out renal stones. So I just did a quick kidney sweep, didn't see any hydro, and then moved on to where he was tender. Next slide, please. And this is the area where he was focally tender. Anybody want to describe what they're seeing or what they think this might be?
Definitely looks like
So
inflammation.
overall, yep.
Yeah, like cobblestone.
Exactly. Yeah. So overall, pretty nondescript image. We're kind of below the abdominal muscles here. So we have this kind of inflamed fat is what I thought this was, because every time I scan for API, usually like the hot fat catches my eye kind of first. I don't know what this kind of more hypoechoic area in the center was, but definitely abnormal to me, definitely where he was focally tender. Didn't have a great kind of working diagnosis for what this was. And I sent him for a formal ultrasound, thinking that they would be able to find this same spot, and to get, again, some more help from my radiology colleague. Next slide, please. And so the ultrasound saw that same spot. The radiologist called me and said, I see this area of avascular fat that in the setting of kind of how he's presenting might make more sense as an omental infarction or an epiploic appendigitis, and that we could get a CT for further clarification. I thought, this kid has had issues for 5 days now. He's overall well appearing. His labs are pretty benign. He looks good. And so I offered mom, we can treat it as a epiploic appendigitis with just pain control because it's a self-limited process, or get a CT scan for a more definitive confirmation. And she opted for a CT scan. And as you can see on this CT scan, kind of right below the liver there, there's a hazy area with fat attenuation, and then some stranding as well of fat. So again, a very kind of like nondescript area, but consistent with how both omental infarction and epiploic appendigitis look on CT scan. Next slide. And so what are these kind of diagnoses? And so very similar appearance, very similar kind of pathophys and kind of how they infarct and then necrose and it's all pain control and their self-limited process. And so for omental infarction, I think we can go to, for both of these, you really get a mass with kind of a enhancing rim and a hypoechoic center that we saw in my ultrasound and on that CT scan as well. We go to the next slide. And kind of what the difference is between these two. And so for omental infarction, which is my best guess for what this kid had, a little unclear etiology. Some could be low omental blood flow. Obesity is also a risk factor that you get so fat in the omentum that it just kind of compresses the blood vessels. It's usually happens almost the vast majority of the time on the right side, it's right-sided because the blood vessels there, they're longer, more tenuous, more prone to torsion. And you don't get any systemic symptoms. And usually these can be up to 5 centimeters or greater. This kid's measured about 5. And another risk factor is kind of sudden movements. And so like for this kid, the only 2 things I can think about are, he's at baseball practice, they do some sort of sudden movement that caused this. He also had that kind of congenital cardiac disease with that bradycardia where he never really got above 45. So I'm thinking if he's doing activities, is he not generating enough cardiac output, and had a little bit of an infarction event. A little bit unclear. For epiploic appendicitis, that's referring to those kind of little fat tags that hang off the Taenia coli that I remember from anatomy almost specifically in cadaver lab. And those can tors along kind of the stalk. Way rare, more rare in children than in adults. And usually in adults, you're usually gonna get this in more of a rectosigmoid area, with your ileocolic area being kind of the second most common spot, with higher up in the ascending colon being kind of the third most common spot. These usually measure about like 1.5 to 3.5. And so for this kid, the size of his lesion being about 5, thought he was more of a mental infarction than epiploic appendicitis, but the actual diagnosis would be an X-lap determining what was actually TORS, which obviously he didn't undergo. Next slide, if there's another one.
Yeah, that's it.
That's it, yeah. So any questions with this guy? I think in the future, if I see kind of that kind of generic hot fat signal in a focal area distinct from McBurney's point, in a kid who really isn't acting like an appendicitis and isn't having multiple symptoms, I might feel comfortable making that diagnosis, especially if the labs don't show, a big white count, which is considered normal labs. And so another rare kind of diagnosis for a rule out API.
I was telling Jason yesterday, I had a young man come in to the emergency department 2 days ago. He was in his Zoom school, and he had sudden onset of first testicle pain, and that seemed to go away. And then he came in with left lower quadrant tenderness. When he first came in, he looked really uncomfortable. I mean, he was hunched over. He had a hard time walking. He couldn't sit down or stand up from the stretcher. His testicle exam was pretty normal. I mean, I still ultrasounded his testicles because, again, we don't want to miss that. And he just continued with left lower quadrant tenderness. He, like I said, he was doing very healthy young man, also had a low resting heart rate. And his testicular pain went away. And he did continue for a little bit longer with the left lower quadrant tenderness. And that ultimately did resolve with pain medicine. And I did not scan his left lower quadrant because I said to myself, there's no organ really in that left lower quadrant. And, I think after this case, I think I'll consider those, vague abdominal pains, if it fits, to take a look, which I hadn't considered before. All right. So I got one again. I feel like, except for our MSK case, I feel like everything has been GI here. But I'll call this one. This is an oldie but a goodie. So this was an 8-year-old boy who presented with vomiting and diarrhea. We have a huge cardiac center here, so we see a lot of kids with very complex heart disease. He had a history of hypoplastic left heart syndrome and status as transplant several years earlier. He was coming in with URI symptoms for a week, and then developed vomiting and diarrhea one day prior to admission. Actually, the diarrhea started first, and he was having some crampy abdominal pain. His mother, who was very savvy, had given him Zofran, just to try to see if she could treat the symptoms, but he continued to vomit. Just like that patient I had before, again, I feel like we're lighting up here with all of those physical exam. He was ill. He was cyanotic. He was tachycardic. He was poorly perfused. He was grunting, tachypneic. I mean, he looked very ill. Exam was very difficult because he was diffusely tender, but I did think that his liver was enlarged, but I couldn't really feel the tip. And again, he had very poor perfusion. So in my mind, I was thinking more so about, having his GI symptoms. And so I started out looking at, his IVC. And in this child who was coming in with vomiting and diarrhea, that was just not what I was expecting to see. I moved on to his heart. And so you can see obviously in his parasternal long axis, didn't look any better in any of the other views. And then apical 4. So our cardiology team is very hands-on with their patients, especially. We have a whole protocol in order when patients are in our trauma rooms. So just to put a timeline on this, he come to the emergency department just shortly after 9 in the morning, and was put in our recess bay. I don't know what took them so long to get back there, but within 10 minutes we called cardiology, and he was admitted within just over 30 minutes after presentation. And then he was transferred out within an hour of arrival. So his findings were concerning for acute rejection. He did have an RVP, and the reason why I put this in the slide, I just thought it was really interesting. He had rhinoenteral, I think like every other child who's coming into the emergency department, and RSV. And the reason why I thought that was interesting, I don't know what y'all are seeing around the country. At May, it's usually at the end of RSV season, but we are seeing a lot of kids with RSV, which I find very interesting because we're seeing 0 flu, but we're seeing a lot of RSV. So again, I don't know what y'all are saying. He had, in addition to his heart failure, he also had multi-organ failure. He was started on ECMO, which they continued for 5 days. And he had a prolonged hospital course, but was ultimately discharged after 5 weeks. And he did well. So that's all I've got. And if anybody has any comments on that last case, or any comments on what y'all are seeing right now, I just want to thank Henry and thank you guys for letting us share some cases with y'all today.
Thank you, Stephanie and Jason. Those great cases. So definitely thank you. They were just mentioned in the chat that the function was way down as there, and Matt was scared of what it looked like. So. But thank you again. I don't know if anyone else has questions, but thank you so much, both of you, for presenting. We have a second lecture. We won't start till 2 p.m. So feel free to ask more questions, or and then you can log off or come back in, but we'll be starting at 2 p.m. with Dr. Levine's lecture.
All right, guys, just wanted to get started by introducing Dr. Levine. I met Marla when I was interviewing for a POCUS fellowship. She was at the time faculty in Brooklyn at Maimonides. Since I got really excited that next time I visited Austin, I could have food truck explorations with her, but she has since moved from there as well and is now on faculty at Vanderbilt. We invited her to speak to our group today as both of our fellows are going on to positions where they're going to be the POCUS point people. One at a place that doesn't really have a POCUS program to start to speak of at all, and one who's going to be the pediatric point person in an institution that has a program in the adult world. So one of our goals for the remainder of the year was to look at administrative aspects of POCUS. And Dr. Levine is going to be speaking about the consensus statements and policy guidelines that are that exist at a national level that support the use of POCUS in the pediatric emergency department. So we welcome her and thank you for coming.
Well, thank you so much, Matt. Let me share my screen. Okay, let's do this. Okay. And okay, I was wondering if people could put their videos on. I would love to see faces. If that's okay with y'all. I miss humans. I mean, we do see humans, but I love interacting with people when I lecture. So thank you for those who just put their videos on. I love to see your faces. So I'm going to start by thanking Matt for inviting me to speak because I think this is a really interesting topic. And I learned a lot over the last several years, both in my move to Austin and now in my move to Nashville. And I think that there's a lot of wisdom that we can gain from the publications that are available to us. And that is why I think going over the policy statements is incredibly important. So we will begin. So the objectives of today's talk, we're going to talk about the key policy statements in point of care ultrasound. And then we're going to talk a little bit about the informal ingredients in creating a point of care ultrasound program. So for all of my graduating PEM-POCUS folks who are going off, y'all are embarking on an important journey, and it can be a little bit daunting. And so I think the thing to know is that you have a huge community of people out there who've gone and done this. And I encourage you, as you're listening to this lecture and beyond, to really remember who your family of POCUS people are that you can lean on as you start your own POCUS program. You may, for those who are at established programs, I think it's easy, especially those that have been around for a long time where everything is pretty much set out and clear and everything is in place and your storage system is there and your billing and coding is there and everything is there and it's easy. Know that that's not how it's likely to be as you start your program, because you're starting at step one. And I think it's important to just be mindful that every program that's established encountered bumps and hurdles and challenges as they were establishing their program. And it's okay that you encounter those bumps because it's part of the process. So expect it to be a more, it's probably not going to be as much of a linear trajectory as you anticipate, and that's okay because you will learn from each hurdle you encounter. Okay, to know where you're going, it's important to know where you came from. And by you, I mean us as an ultrasound community. So the first published position statement came out in 1990 by ASAP, and it was more of a we can document. It was a document that delineated that ultrasound can be part of your practice in emergency medicine, not peds emergency, but just emergency medicine. In 2001, ASAP came out with the ultrasound guidelines, the first iteration. It was a document that delineated a little bit more clearly that ultrasound could be part of your practice. In 2008 was the first policy statement. That was, we can and should do this. This should be part of your practice as emergency medicine providers. You should have knowledge of ultrasound in your practice. In 2011 was the first fellowship guidelines put out by ACEP. And just to give context, myself and Stephanie were doing our ultrasound fellowships in 2011, during the 2010 to 2011 timeframe. So this came out, you know, even while some of us, the people that kind of have been doing this for about 10 years now, were getting our training. 2015 was an important year for us as PEM POCUS people, because that's when the policy statement came out for PEM, point of care ultrasound, or the position, the policy statement speaking to PEM POCUS. And then what we're going to discuss now is the 2016 ACEP policy statement, because that's really the most important document out there right now to guide your practice. And it's not a, like, as opposed to the previous iterations of the policy statements, this isn't we can do this, is that it's a we are doing this. This is part of your process as an ER doctor. You will be using point of care ultrasound in your practice. And so with that, let's talk about the policy statement. So this is your Bible. Okay, as you are going out there, this is a document that if you haven't already printed it out and gone through, I highly recommend you have it in your back pocket, because it is really going to speak to a lot of the things, the questions, the challenges that you may encounter. This is an important document to serve as your evidence. The roadmap of this paper involves 6 key areas. So we're going to talk about scope of practice, training and proficiency, credentialing and privileging, quality and ultrasound management, value and reimbursement, and clinical ultrasound leadership in healthcare. Okay, and also, by the way, as we go through this talk, if you have questions, if you have comments, if you just want to chime in, please. This is meant to be a discussion. I want you to get a lot out of it. And there's a lot of very important people on this call right now, on this Zoom meeting. So this is an opportunity also to learn from other people's experience. In terms of scope of practice, when we talk about emergency ultrasound, and you all know this, this is also referred to as clinical ultrasound, bedside ultrasound, point of care ultrasound, physician performed ultrasound. We are not radiologists. We are not radiology sonographers. We are not doing comprehensive studies. We are doing targeted studies that are performed at the bedside, interpreted at the bedside, and integrated into the care of your patient. So when you are discussing what we do in point of care ultrasound with radiology or cardiology, it's important to be very, very intentional with your words. We are not doing exclusive imaging. We are not doing comprehensive imaging. We are doing point of care imaging. This is a separate billable procedure. So you can bill for this procedure if they're getting other radiological studies. Now, you can't do this if you cannot bill for an API study if you are then sending the patient to radiology for an API study, but you can absolutely bill for a fast exam before they go for their CT scan, or if you get an ultrasound to define whether or not there's well, you should be doing your own point of care ultrasound for skin soft tissue, but let's say you send them to radiology to get an ultrasound to see if there's an abscess, you can still bill for ultrasound guidance of that as you're draining the abscess. So just know that what you're doing has financial value, and it is separate from those studies that are being performed by other specialties. It is distinct from physical exam. And I'll be honest with you that when I was starting out, I really did kind of frame it from a standpoint that this is an extension of the physical exam, but I think it has the intention of minimizing the importance of what we're doing. It's not part of the physical exam. It's a really, really special skill. And so even though it can follow your physical exam, it's definitely not part of the physical exam. It is a billable procedure, and keep that in mind as you go forward. When we talk about emergency ultrasound, it falls into 5 different classifications or indications. Resuscitative, so that's, your coding patient. Diagnostic, if you have a clinical question that you can answer in a yes/no fashion, this is your kind of the diagnostic arm. Symptom or sign-based, you're a patient who comes in, for example, with dyspnea, and you do a full thoracic study. Procedure guidance, ultrasound guided IVs, your ultrasound guided paracentesis or abscess drainage. And then therapeutic and monitoring, obviously, once you do a study, it doesn't mean you can't do it again. So if you're concerned about your patient, it makes a lot of sense to repeat that study, especially in your trauma patient where there's a positive FAST, or your patient who maybe put on some respiratory support and you want to check the status of their lungs while they're getting additional support. In terms of the 2016 guidelines, it speaks to 12 core applications. Now, what's important to note is that the expectation is not that everybody who does point of care ultrasound is expert in every single one of these indications. Rather, these are all the indications that people who are graduating from their EM residency may have gotten experience with. This is not, it doesn't mean you can't do other applications. If you've learned how to do ultrasound guided nerve blocks, by all means, go forward and do it. It's part of your practice. But this is kind of that comprehensive list as of 2016. And I can tell you, when we were starting out back in 2011, like lung was not on it. I mean, lung ultrasound was something that came into discussion in 2011, 2012. So even before my training, when I was getting my training, we were not taught at the beginning how to do lung ultrasound. That's true also of like musculoskeletal wasn't really being done very much for long arm. So this is definitely or bowel for that matter also. We weren't doing bowel studies regularly. So this is like an evolving delineation of core applications. And as more and more studies become mainstream, this list will change. And it is interesting to see how there has been significant changes even during my time in ultrasound medicine. So emergency physicians should have a basic education in physics, instrumentation, procedural guidance, and fast exam. That's a pretty basic expectation for all EM physicians. You're not expected to be expert in all 12 applications, and you'll pretty much become expert or competent in, Gigi, sorry, that's my dog, she likes to steal the show, is going to be based more on where you practice and what are the applications that you do at your shop. So this is another area that's really grown in the 2016 document, which is the other settings and populations. And a big one for us is the fact that now pediatrics is one of those spaces where point of care ultrasound is incorporated into our practice, especially since the policy statement came out, the PEM policy statement came out in 2015, and then this revised ASEP policy statement came out a year later. So it's very well accepted that this is something that we're doing in pediatrics. This is an expectation of ABEM that people who are coming out of their PEM training have some working knowledge of point of care ultrasound. So that's been a huge change. Critical care is starting to come on the scene in a more significant way. Very recently, I actually had a conversation with the PICU here at Vanderbilt with their interest now in doing kind of more of a formal curriculum for point of care ultrasound with their fellows. So many of you have probably encountered that with your PICUs and NICUs where they're wanting to have this skill set available to their patients. I think pre-hospital is definitely one area that I think will grow a lot in the coming years, because not unlike practicing medicine in austere environments, you know, your pre-hospital providers have very limited information. I mean, they have their stethoscope, their hands, and, you know, very basic monitoring devices. With the addition of ultrasound and now with the handheld devices, I have a feeling this is going to become more and more of a mainstay of therapy in our pre-hospital population. I can speak very passionately about the international environments. You know, there's definitely with Pure and other very big groups, there's been a very important recognition that ultrasound is life-saving technology, especially in resource-limited settings. We're very, very lucky in North America because we, you know, if you don't have point-of-care ultrasound expertise, well, you'll just send your patient to radiology, or you'll get a X-ray or a CT scan, and all of those things are readily available to us. However, when you're in a resource-limited setting, it could be the difference between life and death for your patient. Right then and then, the ability to ultrasound your patient and gather information that they otherwise would not be able to get in a timely manner. And so there's been a tremendous amount of growth in that sphere as well. Military and tactile, they've been using this for a long time. They were probably one of the earliest adopters of point-of-care ultrasound, but not surprisingly, it's still a very important part of their practice. So in all of these settings and populations, the guidelines just speak to the importance in other care settings. Training and proficiency. So the definition of, so competency is one of those like words that we like talk about all the time. But it basically means it's a progressive development of increasingly sophisticated knowledge. I can't even see the end of that slide. I'm so sorry. Knowledge, and my screen is weird. Hold on. Anyways, you can see it. It's blocked off my title. Jason's shaking his head. What is
psychomotor skills?
Psychomotor skills.
Psychomotor skills.
Thank you. I'm doing this without notes. In terms of the ACEP definition, it's actually very, very defined. So it's, whereas competency is kind of like a fluffy word, like what does that mean really? ACEP definition really kind of breaks it down. It's recognizing the indications and contraindications. It's the ability to acquire adequate images, right? So it's not just the ability to capture an image, but it has to be an adequate image to actually make, so that any other person looking at this image can understand what you were concerned about and what your working diagnosis is based on that image. You have to be able to interpret those images. So it doesn't just matter that you can capture the image, but you have to be able to read it. And then you need to integrate that ultrasound exam to the patient care plan. So how are you going to use this information? And all of those things fall into this subset heading of competency. Okay, this is important. So with training and proficiency, what is part of your emergency ultrasound curriculum? Okay, this is the meat here. We need faculty with expertise. This faculty needs to have the time, and there has to be an investment on the part of the department on resource and departmental support. That's the only way to do this. So if you're going to a shop that does not have a director that's going to buy into these requirements, you're not going to get far. Okay, there has to be an investment on the part of the department, both to give you the time and the resources to do the education to train up the department. Now, I can speak when I was a fellow, I remember every month as the EM residents would come into the department, I would end up giving one of like 3 or 4 lectures every single month, the exact same lecture. And it was by the end of like my fellowship year, I was like, I can't listen to myself talk about this anymore. It was so like mind numbing. And one of the really important innovations that has happened is this educational innovation. The flipped classroom is probably the most important addition to is one of the most important ingredients that's going to make your job a little bit easier, which is that while you're going to be tasked with teaching folks, that didactic component can be done in a flipped classroom modality. So the foam ed landscape is incredible, and you're going to become like the foam ed curator. So you're going to go through and figure out what are the things that you think are the best resources for your learners. But the reality is they can go online and find a video on almost anything, do it on their own time whenever they're best able to learn. So that asynchronous learning is also really key because, for a lot of folks, they're not going to learn best when you're sitting or standing in front of them. It might be at 11 o'clock at night, or it might be, while they're on their treadmill. Whatever it is, learners know how they best learn. And now with this, putting the onus of responsibility on the learner to learn the didactic really helps us out. And it also basically preserves our teaching time for more of that psychomotor skill set, which is probably the hardest thing to learn for a lot of novice learners, is how do you hold the probe? How do you do changes on the machine? How do you do subtle adjustments with the probe and the patient to capture the images? And that's your expertise. That's the thing you're going to be providing to your learners is this kind of hands-on educational support. In terms of demonstrating proficiency, this is discussed as either the set numbers benchmark or more of a simulation observership kind of method of assessment. I would say for most of us, we don't have time to do OSCEs on all of our learners to determine at what point they are able to go and practice autonomously. I think for many of us, the set number benchmark is just a little bit more of a time saver for those of us that either are practicing alone or don't have that much time protected for POCUS. So in terms
Marla,
of, yeah.
Oh, well, I just wanted to interject. So this is something that in our program has taken several years to develop, but we have for our fellows a longitudinal curriculum, and the fellowship directors requested to have a biannual assessment. So our POCUS education director, and I'm not the only person here, there are, you know, a cadre of us to be able to get this done. We have an assessment in January and then again in June, and then we focus on different skills for our first years versus second years versus third year fellows. But again, this has taken some time to build up.
Right. And also, Stephanie, how many educators do you have in your shop?
You mean POCUS educators? There are 4 faculty, and we have a wonderful fellow.
I think I know your fellow. Right. So that's just it, is that there has to be a real investment on the part of your department to create this. And obviously in that setting, when I was in New York, that was part of the assessment of the residents too. I mean, that was a commitment on the part of the EM chairman and the residency director and the fellowship, the ultrasound team, to do these OSCEs, but it does take an investment on the higher ups to make that happen. And I could tell you, I don't, in my current position now, I have it's just me and I have one shift down in my shift reduction. That is never going to happen in my shop now. In the future, let's see. But I think that's very encouraging that some of the bigger programs have really committed to more of a supervised assessment modality for evaluating their fellows.
I just wanted to add one more thing that somebody showed me a couple of weeks ago. At Emory University, we have access to a program called Canvas. I don't know if other institutions are using it. I don't know that it has to be institutionally related, but one of the POCUS faculty members in the Department of Critical Care and Anesthesia developed his curriculum and put it on Canvas. And so just like you were talking about with the asynchronous learning in the flipped classroom, there are programs online that you can you can create your own curriculum and have the students go into it on their own time. And in Canvas in particular, there are ways to track that the learner has completed the activity. And if you put any quizzes in there, there are ways that Canvas will grade it for you. So there are programs out there that can do a lot of these, can assess and track a lot of these, flipped classroom type of activities.
That's amazing. Thank you so much, Stephanie. I wasn't aware of that, but I'm definitely aware of that. So thank you for sharing. So just quickly back to the benchmarks. ACEP calls for 25 to 50 quality reviewed scans. If you're going to be using the numerical assessment, there has to be a subset that do have pathology, so they can't just be all normals. For those who are doing their training at places where they do a lot of different ultrasound applications, the benchmark of 150 to 300 scans is what many of us will use. That's what I used in my last job, and this is what I'm using here as well for my fellows. And then for all of those procedure-based applications, you need a smaller number. Our nurses are incredible at ultrasound-guided IVs, and they have a kind of a self modulated training that the nurses will do with the younger nurses or the newer nurses to train them up in ultrasound guided IVs, and they use 10. So they're using even more numbers to just ensure that everything is on the up and up, but ACEP only requires 5. So there's various ways that people are going to get their training. There's the residency-based pathway, and this is how all of our EM residents are getting trained up. It is a mandated competency for ACGME, and it's become a patient care milestone. It's number 12. So it's one of those areas that they're being evaluated on regularly. The practice-based pathways are the courses. These are the courses that many of us have participated at, AAP or Gulf Coast or the regional courses that happen in DC or in Connecticut, Rhode Island. So these are just the ways that other people, those are the PEM courses, but obviously there are adult courses all over as well that can get people the training if they didn't get that training during their residency training. And obviously fellowship training is designed not to create users, but to create experts. So, you know, if a person just wants to get trained up, the ultrasound fellowship is way more than they need. But that's what you guys who are going off and graduating up this year, like the intention is to become the leader. And that's across the board, regardless of who's doing that ultrasound fellowship. By and large, it's to become the leaders within departments. So you may come up against a little, so this is something that I even remember when I was interviewing for jobs when I was still in my ultrasound fellowship, but kind of a little bit of the territorial nature that some specialties can have when it comes to ultrasound medicine. And just so you know, the AMA put out a House resolution, this was back in 1990, House Resolution 802, which is that ultrasound imaging is within the scope of practice of appropriately trained specialists. This is something that we are allowed and should do if we are trained to do it. And any opposition that seems to be more financially mediated is actually an ethics violation. The AMA also put out a recent House resolution, again, reiterating privileging and scope of practice with ultrasound medicine. That actually came out very recently. So again, the AMA is fully endorsing of the fact that we as EM or PEM, POCUS people should be doing this as part of our practice. Also, the privileges, when we talk about privileges, that's something that your department and your your institution decides. It's not other specialties. So that's another important nugget, is that this is like, we moderate and control ourselves. This is not something that other people decide how to achieve those privileges. Quality and management. So in order to, when you start your program, there has to be a process in place for quality assurance, right? So if people are going to be using it and people are going to be training, there has to be somebody who's looking over the imaging and making sure that everything is being done well, with good oversight, that all the systems that you put in place for your program are being respected. So quality assurance, you know, if there are incidental findings that you come upon, that has to be relayed to the patient, making sure that, you know, especially while people are getting trained up, they have to know whether or not they're doing what they need to do to reach their competency requirement. And then obviously, once they're doing this autonomously, you need to make sure that people are using ultrasound properly in the care of their patients. What is the job of the ultrasound director? So you all, I'm sure every person on this call is either an ultrasound director or an ultrasound fellowship director, or is some other director, because that's what happens when you become ultrasound fellowship trained, is that you join a group and you develop some sort of leadership role, because that's, you have just done this additional training to become the expert. So you're going to figure out the goals for your program. You should be involved in machine selection and maintenance. You're going to create the credentialing and privileging program with the physicians and or with, so it might be just with the physicians, or you might be working within the hospital to delineate what is required for point of care ultrasound in PEDS emergency medicine. And then you're going to be overseeing the QA process and giving feedback to your users. Part 5 is value and reimbursement. And this is, a lot of this kind of goes without saying, but bears being said. You're improving patient safety and reducing errors by using ultrasound in your procedures, right? This is the IOM clearly delineated that now for central lines, all central lines should be done using ultrasound guidance. This decreases complication rate and improves the care of your patients. Studies have shown that ultrasound improves patient satisfaction. This is a really important way of improving resource allocation in your hospital and also in your department, and also throughput of your patients. It can eliminate costly or invasive procedures and can help you with your medical decision making. And like with anything, right? Whatever you do should be documented. Well, that goes for ultrasound too. And, you know, that's one of the more challenging. I could tell you, I got to Vandy in August. We got a new machine very recently, which was a wonderful win. And on the adult side, they have a very established billing and reimbursement for their adult EM studies. And we're all part of Vanderbilt University Medical Group, but for whatever reason, on the PED side, there's a little bit of a resistance to billing for ultrasound. And that's going to be my next big undertaking in this next academic year. Because this is something that can really help your department, right? This could be how you get your next ultrasound machine. This could be how you hire another ultrasound educator. There is this doing the ultrasounds, documenting them, billing for them has financial value to your department. And there's a CPT code for it. It translates into RVUs. And I can't tell you what those numbers are because that's very much dependent on the institution and the insurance spread and all the things unique to your institution. But regardless of where you're practicing, it can only help in terms of your bringing money into your department if you actually document, store, and submit for coding the ultrasounds that you're doing. So clinical, last part of this big document is clinical ultrasound leadership in healthcare systems. So as mentioned, a lot of other departments are expressing interest in using point of care ultrasound in their practice. And you, having been fellowship trained, have this expertise. So you will probably be called upon at various stages to provide this education to other, in other clinical settings. These other spaces, like for me with the PICU, like we were talking about everything, that they have to hire somebody that will be their leader, that there has to be administrative oversight, all the things that we just discussed now, that has to come into play regardless of who's using point of care ultrasound. So that needs to, if they want you to be that person in a PICU or a NICU, well, then they have to be providing that administrative support to you to oversee that training in that space. Now, I would say one of the other things is that as ER physicians, because we interface with so many different specialties, we're also uniquely poised to become hospital POCUS people. And so that's something that, like, once you kind of become that PEM POCUS leader within your division, you know, the sky's the limit with where you can go with your point of care ultrasound expertise. It may take you to the medical school and in terms of incorporating ultrasound into pre-medical education. It may take you at a hospital level. So just know that you're not, once you start your program, it doesn't end there. There's a lot of opportunities. And what you'll see actually within the spread of the people within this community is many people started out as POCUS or directors or POCUS fellowship directors, and then they went to chair or director, and then they were, you know, other, and so on and so forth, because you really have a good understanding of the administrative landscape within your hospital, and you interface with a lot of people, and you're also recognized as a leader. So congratulations on joining this important community. All right, we got through the policy statement, so I hope that wasn't too thick, but that's really the nuts and bolts of what we do. So now everybody take a collective deep breath. We got through the POCUS, the policy statement, and now it's a new day. And the reason I say that is for those of us who started point of care ultrasound, you know, 2011, 2012, 2013, we were all practicing in silos. We were all practicing our PEM, POCUS within our respective institutions, and everybody kind of was doing their things, and case reports were being written, and here and there some prospective studies were coming out. And then in 2014 we did something really amazing. We came together. We bound as a group of these. In 2014 we were 50 people. So let that sink in for a second. We were 50 people across the United States, Canada, and internationally that were PEM POCUS people. Now, not all of us were in leadership positions at that point, but we were all the enthusiasts. We were all putting out research or case report. We were doing the things, but we were all practicing independently until we got together in 2014. And in 2014, at Sick Kids Hospital in Toronto, we created the P2 network. And this was pretty monumental. And I'm sure you are all part of P2, and now you can see that the scope is so big in terms of what we do, in terms of our collaboration. But this started as just a small group of people who met up. From there, in 2015, Jen Marin and Risa Lewis put out the policy statement. And this was really that moment in time where all of those departments who were like kind of plus minus into POCUS, plus minus into having POCUS as part of their curriculum. This was that moment in time where everybody was like, oh, we need a POCUS leader. Because it was now in this document was really the understanding and expectation that this should be part of the training of our PEM fellows, and that in order to have that training experience, you have to have a lead. And so this was an important time for those of us who were in POCUS at that time, where we finally had the street cred that like we're here and we're not going anywhere. If ever you have, several hours and want to read a fun 83-page document, this summary of evidence is basically all the studies that justified the different applications that we were advocating for in this policy statement, with all the studies that supported it, all pitfalls and pearls, literally everything that was in the literature as of. It was published in 2015, but like we all started working on it a couple years before. But it's a great document. Obviously, it's probably a little bit dated now because there's so much more literature that's come into the landscape. But it is a really interesting kind of document that delineated where we were at that time when we were advocating for PEM POCUS within the pediatric emergency medicine sphere. The document, the policy statement document written, that one was just written by Risa and Jen, basically, again, first of all, defines the fact that like ultrasound should be used in pediatrics preferentially over any other imaging modality, speaks to the radiation risk and keeping our patients safe, speaks to the importance of having a designated leader, and that leader should have expertise in point-of-care ultrasound. And that leader will be responsible for teaching faculty and trainees and overseeing the program. Again, the credentialing piece, if ever you have a conversation with Risa Lewis about credentialing, she will 100% say that the numerical assessment, she has never been a proponent of it. But, and the OSCE is obviously a much better way of doing it, but not everybody has the capability. And so within this document, it again speaks to the 25 to 50 scans. Privileging comes from hospital privileging committees, and if you are starting something de novo, you might want to be part of that. And again, the importance of documenting the indication, interpretation, and archiving of your studies. Okay, so this is not to scale. It's also not, it may not even be super current, because there could be people out there that I don't know who are now kind of going into states that I'm not aware of. Oh, there's some people in Michigan too. But this is just the state of our union. And I spoke about this when we were at the P2 network a few years ago, and there's a few more stars out there now than there were once upon a time, but there's just not that many of us still, even though there's about 200, 250 people internationally that are doing PEM point-of-care ultrasound. Like, if you look at the Northeast, that's still where most people are. So looking at the rest of the country, like, there's still many places that don't have PEM point-of-care ultrasound leadership. And that's something that's important for those people who are graduating now, who are going off and starting their programs, is that there's really an opportunity to bring the skill set to a lot of different spaces that don't have this opportunity as of yet. It is harder to go out to a place that doesn't yet have an established POCUS program, PEM POCUS program, because you are going to be challenged by starting something de novo, and that's not an easy undertaking. I would say the first important step, if you're going somewhere, is really link up with the EM ultrasound director on the adult side. That's the first thing I did when I came here to Nashville. And he is one of the most important allies that I have here, because we really do work together. Granted, he has a tremendous amount of protected time and he has everything very established, and that's all great, but I have to start at step one, and step one is really in making the relationships and having the opportunity to really grow this. You need the support of your people, and your people are going to be your EM colleagues. So use them, know them, lean on them. I can't impress upon you enough. And for those people who are in the Northeast, if you're ever thinking of moving, there's a ton of children's hospitals out there that are still looking for people to lead point of care ultrasound. So maybe not this past year, because this past year has been a challenging year for everybody. But hopefully now that volumes are going up and we have more dedicated time to teach again, your expertise will be very much needed and wanted. Okay, so now this is like this is my piece. This is my informal wisdom. Now, your birthing of the POCUS program will probably take more than 9 months, but every win is a win. And I would say, let your higher ups know when you have the wins, when ultrasound is acknowledged to be the thing that helps your patient. Your people should know this. Your director should know this. And it is a good idea to let people know when the win was because of this really remarkable technology that you are bringing to the department. Mentorship. So I cannot speak more about the importance of mentorship. Even to this day, I still speak to Risa like every other month-ish. And I could tell you, when I was leaving New York on my way to Austin, I spoke regularly with Jen Marin and Adam Sivitz and other people too. I spoke to Dave Tang, I spoke to Alex Royo, I spoke to Dave Kessler. I spoke to everyone that was in my my bubble of help. I spoke to them. I sent them my CV, my delineation of my job description, all the things. And I had my people weigh in. And mentorship and guidance, that is truly the whole thing about mentorship, is people who are established as your mentors, they are invested in your success. That's how I am with my mentees. That's how my mentors were with me. And so lean on them. That's what they're there for. People who are invested in education, there's nothing more important than the success of the people behind them. And I was very privileged to have wonderful people on my team as I was starting out, and I continue to lean on them as I, go up for things. And I encourage you, as you're starting out, lean on your people, because that's what they're there for. Collaboration. So what came of P2 is, as opposed to how things were before we were organized, where we were just putting out case reports and these small little case series, through P2 we've become this beast of research production. And getting involved in these studies is a further way of kind of showing your department your involvement in landmark literature that's being put out there. So get involved, collaborate with your colleagues, get into P2, present at, do we call it PEPEC? PEPEC? The collaboration. I don't know how to say this acronym. AIUM, ASEP, SCUF, all the things. Just become involved, meet people, network. This is how you build your career, and give, let the people that you are working with, your director, it lets them know that you're part of this community, and that's really, really important. Also, by the way, as you're going up for promotions, these kind of opportunities, getting involved in the research, collaborating, speaking, all of that becomes really important as you're going up for a promotion. So just another thing to keep in mind. I very much believe in not reinventing the wheel. So lean on your friends. So when I was starting my first program out of New York, when I was moving to Austin, I went to, my parents live in Toronto. So I was in Toronto and I reached out to Jason Fisher and I'm like, Jason, can we meet? And we set up a meeting and I sat with him and he basically told me everything he had gone through. And at the time he was already the director, like the director of PEM, not just of ultrasound director at Sick Kids, but he essentially like gave me everything he had. So like, he's like, this is what I did, here, take it. And it was amazing because he was just, what you'll see is people are very generous with the things that they've created. So Sick Kids gave me their document. Then I contacted Alyssa Abo and Joe Cohen at Children's National. And I'm like, can you share with me what you have? And they're like, yeah, here, take it. And the same thing happened at Rady Children with Atom. And the same thing happened at Texas Children with Kaida. And the same thing happened at Norton Children's with InChem. And what I did is I took all of those papers, like all of the documents that they had created. And I'm like, I don't have to create this de novo. I basically have these amazing colleagues and I just kind of put it all together in a document that worked for me when I was in Austin. And that's the way you do it. You lean on your people, because why start something? Why do you have to sit there and kind of research and do all the things? We are a community, and as a community, we want everybody's success. So we share, and it's okay to ask people for what they have. They will share it with you. And if they don't, have them come to me. Come to me and tell me, because that's not our community. We share with each other. Okay, director buy-in is important. It's how you're going to get your time. It's how you're going to get your machines. Okay, so this faculty credentialing piece, if anybody has figured out how to make this happen, please let me know. I solicited that request when I spoke at P2 a few years ago. I'm still met with the same, I don't know how to do this. I've spoken to my mentors. Nobody really knows how to do this. I think it is one of the hardest things is getting doctors who are already in practice to go back and learn a skill that they don't really feel they need, especially, again, we have all these other resources. We have ways of gathering information. But I really would love for my department to buy into this. And I don't know how to do it. The only experience I have where we did have physician buy-in, faculty buy-in, was when I was in New York, and your bonus was essentially tied to your completion of a certain number of scans. So that's the only way that I know of to get people on board with, or faculty on board with training. But if anybody has any other ideas, please share. Excuse me, your director is also really important in terms of navigating like your intra-facility challenges. So, you know, if you meet resistance with radiology, or cardiology says, I don't really want them doing, you know, focused cardiac or whatever, your director is that person that can help you make nice with the other departments, and for them to understand that you are not taking, you're not fighting for the same studies that they're doing. We are just trying to gather information on our patients so we can all take better care of our patients. Fellows are low-hanging fruit, and this is always the case. Whereas your faculty, it can be incredibly challenging to get them to your, at least in my experience, in all the places I've worked thus far, faculty, it's so hard to get people to learn, and fellows are so thirsty for that knowledge. And that is a great thing, that at least we have a subset of our department that just wants to learn this skill. And I can tell you, there's few things that bring me quite as much kind of pride as an educator as when I have my fellows contact me and say, I found the appendix, or diagnosed this kid with compromised heart function and communicated that with the POCUS, with the cardiology fellow, and like all the wins, right? Like that's an amazing thing, because they want this knowledge. They're invested in getting this knowledge. It is not hard. They like to get them to buy in. They love it from the start. And you know, while it may take longer to get faculty on board, the more fellows that you have in your department who are using ultrasound, that is often, not that it's often, but it can be the impetus for certain faculty members to decide, you know what, maybe I should learn this. Maybe I should better understand how to use this technology. So future chapters in this talk, the maintaining competency. I mean, that's something, once you've basically established that your people are competent and can use this training, this skill, this technology in their skills, in their care of their patients, it's how do you then ensure that they're maintaining competency? So that'll be for the future. How do you make your program money? That's something that like that takes. It's not going to be a just you thing. There has to be other people who are using ultrasound, who are credentialed in ultrasound, who are using ultrasound, adding it to their RVUs. So, and then ultimately you're going to be bringing more money to your department. That's going to serve your department. And then, you know, this concept of becoming a stakeholder in hospital-wide POCUS. I think for a lot of us, you know, we want to be, if other departments are using POCUS, we want to be part of that discussion. And we are very, very well suited for that role. So that's definitely something to keep in mind for the future. So as final points, know your policy statement. I would print, I mean, for those who are starting out, I would print out this policy statement, read it cover to cover, including all the appendixes, just so you know kind of what ACEP says, so you can speak to it pretty comfortably. Keep your mentors close. I don't care where you are in your journey, they're always important. Join your community, be part of your community, present, collaborate with research. That's the way you further your career. And then don't reinvent the wheel, lean on your people. We're here as a community to help each other. So with that, and in the words of Linda Richmond from Coffee Talk, talks amongst yourselves. That's all I got.
Awesome. Thank you, Marla. That was really a wonderful summary of what it takes to get started. Any questions or comments that people want to share?
I just want to say, like Antonia said, that was a really inspiring talk. I'm now really excited to go on to my next role and get this started. I did have a question though. You were saying that in where you are right now, you're getting into some roadblocks into billing in the pediatric side, where it's like fully functioning on the adult side, which I think is going to be the same situation where I'm going to be at next year. Can you talk? I guess I'm just like, what are the roadblocks that you're facing, and I guess how are you gonna try to go about them?
Yes, that's a great question. I reached out to our builders and coders and I said, hey, what do we have to do for integrating point of care ultrasound into billing and coding? And it was kind of met with, we just don't do that. So then I reached out to my director and I'm like, hi, Dr. Estrada, let's talk about this. And she said, yes, this has been a challenge over time. I have to tell you that because I got here in August, my first big thing that I'm like, I'm going to make this happen was getting a new machine. So we had an old Edge that looked like an iPhone 4. And that was my first, like, I'm going to focus all my energy. And to the extent that, can I tell you, I literally reached out to somebody who knew Dolly Parton and I'm like, can we ask Dolly for money? And he said, no, we could not. But still, I was literally, we were going to do TikToks, like of us with like our old machine, but like, send it to like the Predators, which is our hockey team. I was full of ideas. I'm like, we just need the money to get a machine. And then the monetary gods came in and got us. So now we have the PX, which is beautiful and wonderful and everybody's happy. So that, I have to tell you, I don't know exactly how I'm going to do it, but it's going to be the next big undertaking. And I think probably the first step is meeting with, so Jeremy Boyd is my colleague on the adult side. Is kind of going back to him, seeing what his process was, and then going back to my director, getting her back to be involved. And then I'm going to start emailing like crazy and figure out what we need to do. And one of the things that's interesting is that in my discussion with the PICU, because they're already using ultrasound as part of their ultrasound guided IVs, I'm like, are you billing for it? And they said, no. So that's a wasted opportunity for them. So I feel like this might have to just be a hospital-wide change where we just collectively say, we need to find out what we need to do to make nice with the billers and coders so that they can understand how to bill for this so that we can get the credit for the work that we're doing. So this is a TBD. I will let you know next year if this was successful.
Marla, it's Dave Tang. How are you?
Dave, how are you? 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 How are you?
Dave, I think you remuted yourself by accident.
Hey, Marla, it's Dave. How are you?
I'm good. How are you?
Good. Now that you're in your second shop, what were lessons that you learned in the first shop that are now helping you in your second shop?
Yeah. So the director buy-in is the piece that I cannot speak enough to. And if you remember in the P2 talk, I spoke about the fact that I had my two dads because I had two bosses. I had the fellowship director and the medical director. And they were differently invested, meaning one could truly care less, and the other person really wanted it because of the educational requirement for the fellows. I think that you have to really have a passionate buy-in of your leader to be successful. And if you don't, then you're not going to be. I also do strongly believe that, so I was in a private hospital. It was like a private system. I think it's different when the collective aim is education and patient care and that kind of piece. I think you're more able to succeed as an educator. It's a very different setup now. It was a lot more, I think you have to have full transparency with your leaders as you're taking on the job. Kind of know where they stand, know kind of their involvement and commitment. And I think I was much more discriminating this time than I was the first time. So that's what I would say to people going out. First of all, like, again, I feel very strongly against these private hospitals, private physician groups. That was just not it was not an environment that I think was conducive to my personal goals, which are education, taking the time, growing your learners. But I think the transparency with your leadership is key. And so I would just kind of make sure you know what you're walking into. And they may try to sell you a lot of like a bill of goods, but I think it's really important to ask the pointed questions. Because you are a commodity. That's the thing, is that for us as PEPEC people, like, they need us. And so there's a lot of things that can be told to you in the time of recruitment that may not necessarily hold true once you get there.
Congratulations. It sounded like you landed well. And listen, we want nothing but the best for you, and it's awesome. I'm just happy you're smiling and happy in your new place.
Thank you, I am. More questions?
Just to sort of jump off of something that Marla talked about, as a very young POCUS faculty member, I would encourage the fellows to reach out to people who you don't necessarily think are mentors as mentors. Through the P2 network, I've sat down with people while I was at Christmas for my family in Pittsburgh. I sat down with Jen and literally had a 2-hour conversation about picking my next job when I was finishing my fellowship. And I had literally met her twice in passing, but she took the time out. And since, I've reached out to her a bunch for various different things. So the P2 network is a great place for that, but don't be afraid to just reach out. There are lots of people who are willing and ready to help and are excited to be part of journeys of different people. So keep that in mind as well.
I never worked with Risa. I interviewed with Risa for fellowship. And then I took the job at MIMO, but I remember walking out of that interview thinking, gosh, I want to be her. Like I want to be her. I want to know her. She was just this, and just so for those who are starting out, like there were so few women in point of care ultrasound 10 years ago. You can look at there's like this picture that she sent me of her and Vicki Noble. And it was like, and then every man who is like known in ultrasound medicine. And so she was such a role model. She was always speaking at these conferences, and she was always a presence. And I remember going up to her after a certain conference, and I'm like, "Hi, Risa, I want to chat." And then it just it continued and continued and continued. And it's funny because when I see her at conferences, she has like a paparazzi. Like, I don't know if you've seen Risa at conferences, and there's like a mass of humans circulating around her who want to because she's that amazing. And I remember when she tore herself away to come to meet with me to catch up, because we hadn't had a catch up in a while. I'm like, it's an amazing thing when you find an incredible mentor. They really take an investment in your journey. And Matt, I couldn't agree more. For all those who are either on this call or people who, whatever, we're all here. So if anybody, reach out to any of us. We all want everybody to succeed. I think that's one of the things that's so nice about this community.
Oh, Marla, I just wanted to say that was great. Thank you. And welcome to the Deep South.
Thank you, Stephanie. Thanks, y'all.
Well, it's now there's more stars in this in the Southeast region. So or this, so
yeah.
But no, Marla, that was great. And hopefully the junior faculty on the line really took some of that information, if not all of it, because it's some really poignant and pertinent and really good experience stuff that I think would carry a lot of people through. So, but anyone who's on this line, know that we are, Henry's done a wonderful thing putting this PEPEC together, that we can actually connect weekly, and we should probably have a point where we can probably have a therapy session on things that we've gone through for the junior faculty, and hopefully give some mentorship. But P2 is this thing that I get to hang out with, not only nerds that like ultrasound, but allow us to kind of network. So I hope to see everyone someday soon, hopefully, for our next P2. And
May 25th.
May 25th. You got it.
All right, we're rounding out the 3:00 hour. So again, thank you, Marla, very, very much for your time, and good to see everybody who joined us. Thank you.
Thanks, y'all.